Well, I thank the Society for the opportunity to be with you and discuss about this topic that is very neglected from the Cardiac Surgical Society, just because we keep on stitching and forget that the means to produce better results is perfusion and physiology, of course. And more than a decade now that I've dedicated my research to perfusion, I found out that I made more friends from the cardiac anesthetist societies and perfusion societies rather than cardiac societies, for the simple reason that we believe that maximizing our technical skills, we have the maximum benefit from our case. But to be honest, what you would see is not this concept. So this was the device that has been demonstrated, is the Gibbon 2 IBM device that was prevailed from mid-50s. And this is the device that is contemporary, well, the type of device that we use. As you see, it made 50 years to have something that is very similar. Of course, there are lots of advancements in these pumps here, but more or less it's the same. So I resemble it with the evolution of telecommunication, and this is the old telephone, and this is the mobile, and it made roughly half a cycle for having this mobile. But again, it made less than 10 years to go from this mobile cell phone to this phone that is not just a phone. It's more than a computer than a phone. So all of them are mobile phones, but this technology is much different. And I resemble it with this system, the minimal invasive extracorporeal system, which made 10 years to be from this conventional CPB to that simple system, but it's completely different to the philosophy. For having the base, why we need to do all this, you all already know that the adverse events from the cardiopulmonary bypass is still with us. Even though we have all these advancements, we still have some deleterious effects to end organs, and the clinical outcome sometimes is not as good as we would like. OPCAP became very popular a couple of decades ago just because we wanted to overcome all these adverse events. But to be honest, what we found out throughout the years is the maximum benefit you get from the off-pump use is that you reduce the series and nothing else. And we all know that Ruby study was a landmark study to temper the use of OPCAP internationally, and now we have one-digit figures worldwide. So with this background, it seemed that there was a space initially some 10 years ago, 15 years ago, for the minimal invasive extracorporeal circulation. And those was the early days. And everything started from this system, which is literally an ECLS system, an ECMO system mounted with a cardioplegia set there. So it was very clear that the difference between these two designs is that there is an absent venous reservoir into the mini system, and that creates a closed system which has no blood-air interaction and all the effects from this. And as well, we do not have shed blood coming from the mediastinum to the system and creates what you've heard earlier on. For all this, the Minimal Invasive Extracorporeal Technology International Society was founded, and as you see here nowadays, we do have more than 250 members, and it's a fledgling society. However, as you see, it's a multidisciplinary society with all three disciplines, as well as other scientists dealing with the minimal invasive extracorporeal circulation, and the industry is there. And what's most important here is that with red is the UK participants, the active members of the society, which is, if you exclude Greece, which was the founding country, it's the first group of country which participates to this society, and this is good. So to discuss about what Mark Bennett previously told you is this paper that summarizes all the definitions and potential benefits of the minimal invasive extracorporeal circulation that comes from 24 departments, as you see, and it's really a landmark paper for our society because it summarizes all the data that someone needs to know about this. So to overcome some criticism from previous speaker, if there is no definition, there is a definition. As you see here, 2 years ago there was a chaos regarding this terminology and what was a mini circuit, because most of these systems were custom made, and everyone thought that if he produces a closed circuit or if he avoids the shed blood, then he produces a mini system, and this is wrong. So because of all these dispersed terminology in the literature, the society decided that it should avoid any commercial term or anything else rather than MIEC, which is the minimal invasive extracorporeal circulation system, and also defined which are the components for the system to be characterized as a MIEC system. So not all of the mini systems that you are using are a MIEC system. And if you want to integrate all the advancements into one circuit, then you might fulfill these criteria for the main components and for the additional components to be a MIEC system. So this was the early years, and the evolution now is that we already have in the literature 4 types of MIEC systems. And if you go from this simple ECLS system with the cardioplegia, as you will see, the modular systems are very advanced. And go one by one. The type 1 we've already discussed. It's a very simple closed system with the cardioplegia line there. But if we add a venous bubble trap here, so as we can de-air the system as soon as there is any air entrapment, for example, when we are opening the heart for aortic valves, then we would need this venous bubble trap, and then we have a type 2 system. And if we add this soft bag, which is a soft cell reservoir, so we can handle the volume of the patient, and we can do more complex surgery like the left heart, right heart of cardiac surgery, then we would need this system, which is the type 3 system. And to go further, if we would like to start with a completely safe system which overcomes all the safety issues regarding massive air entry or massive blood coming from an accident tearing the aorta of the heart, then we would need a modular system with a hybrid system having, it's a type 3 plus this extra component which is a heart cell reservoir in parallel, and you can always convert to an open system as soon as you have a disaster. And this is the system we are using in my department, going from the last decade from type 1 to type 4 now, and as you see here, there is a convention rate of 4% whenever we have a problem. But you can appreciate that the last 5 years of operating on this device to 100% of my cases, redo aortic arch arrest, circulatory arrest, and all the right and left hearts and complex cases, and this is completely safe without any problem. So what's the rationale behind all these MIEC systems? It's that, as you see here, in its flow, these lines are flow, in its flow during the pump, the mean pressure is better preserved with the minimal invasive extracorporeal circulation, and red is the, oops, sorry. How I can go back? All right, and with red is the minimal invasive extracorporeal circulation. As you see, it's not that the mean pressure is preserved better, but the norepinephrine use is less. So this has a result to microcirculation, and as you see here with red is the minimal invasive extracorporeal circulation. It reduces the hemodilution and the microcirculatory hypoperfusion, and also, as you see here, has a beneficial recovery benefit to microvascular organ perfusion. So it's evident from the literature that to physiology level, it's a better device to use. But as Alois Philipp, who was one of the founders of this technology, pointed out, do we have the sufficient data? When I asked him to do the preface, the foreword to my book. And this position paper summarized from our society, what are the benefits from the literature exist. And as you see, class 1 level of evidence, a benefit is for transfusion, postoperative atrial fibrillation, renal function, and improved myocardial protection. So the data is there. But even if we go further for class 2A and level of evidence B, that is something that has to be clarified more. But it is there. It's the systemic inflammatory response, as you've already heard. It's a neurocognitive function and end organ function regarding to lung, liver, intestine, and to microvascular organ perfusion. So to see how this data come from, it's from meta-analysis mainly, which exist comparing randomized control trial. And I would go quickly through these meta-analysis, the existing ones, to see that the more patients that they recruit, the more benefit they find towards MEAC system. So this was the first meta-analysis, 1,000 patients, they found out transfusion as the major component for the outcome. If we go to this meta-analysis, 100 more patients made a result to stroke, blood loss, and maybe started to be mortality, a beneficial outcome. If we go to this one, which has 500 more patients, it's stroke, transfusion, myocardial protection. And if we go to this one, that has 2,300 cases, blood transfusion, arrhythmias, and maybe stroke. And this is the biggest one that has 2,800 patients. And if you see here, mortality has become one of the major beneficial outcomes that favoring MEAC. And this was evident from propensity score analysis, because if we do that, you see that in big numbers, 3,000 cases and more, mortality comes as a beneficial effect of favoring the mini-systems. And this is another very recent meta-analysis, has lots of methodological problems, small one, 1,000 cases, but as you see, they found out something. It's just for valves, ICU and hospital stay, which is very significant, because I wrote a paper some years ago that we said the maximum benefit you get from this from using these systems is that the clinical effect of the patient is evident to the cardiac surgical team in ICU. The patient comes warm, neurologically intact, has very limited edema, low lactate levels, and he's ready to be extubated in the next couple of hours. So that gives the opportunity to have very fast-track surgery onwards. And if I summarize all these studies, as you see here, the more we go to the numbers, the more beneficial outcome we find, and also mortality comes there. And if we go to see the raw data from the randomized trials, as you see here, the bulk of the patients that there are, the more of the parameters that they found out that they're favoring the MEAC system. So, finalizing this report, let's say, which are the requirements? I would say that it needs a decisive team, and this is really a multidisciplinary process. And it really necessitates a real teamwork, of course, a stepwise training and a strategy. And when I'm advocating training, we have found out that 50 cases, CABG cases, simple type 2 device or type 3 MEAC systems is enough for a team to become enough expert to go further to do aortic valves and then all cardiac case mix. And of course we need a strategy so as all the teamwork be involved, because we advocate that the circuit is the mini circuit that we've discussed, but the system is the whole system with all the peripherals, the advancements, and also the cell saver. But the strategy is that makes the difference to obtain the maximum benefit of these systems, and that's why we are about to publish this paper with our strategy, which is a multidisciplinary perioperative strategy based on the minimal invasive extracorporeal circulation and to goal-directed cardiac surgery that Professor Ranucci will later on let you know. But as you see here, you need a lot of inline monitoring, so you have a real-time adjustment and a teamwork. This is the anesthesiologist, surgeon, and the perfusionists who are really very close, not just mentally, but also in practice. So to finish with necessity, is it necessary nowadays to have this minimal invasive extracorporeal circulation? Well, regarding the off-pump, as you will see here, the meta-analysis comparing the OPCAP to MIEC seems that they have very similar results. And this is not only in small meta-analysis, but look here, a big network meta-analysis with 23,000 patients. And as you see, MIEC is better to all these hard endpoints, mortality, myocardial infarction, stroke, or AEF, and renal dysfunction. So it's much better to OPCAP. And this comes from people who are OPCAP users. And this allies with our meta-analysis so that there is a mortality benefit if you go to a huge amount of patients, more than 3,000 patients. And for this, we've already designed this trial, which is called COMICS trial, and we will recruit 3,500 patients so as we prove prospectively all this data coming from meta-analysis. And as you see here, this has a great UK incentive because Gianni Angelini, who is here, is the chief investigator to our trial, and we have 24 participating centers so far, and you are more than welcome to participate because we're still recruiting. We believe that we will be able to launch this trial July 2017, and as you see here, it's a big trial with 3,500 cases randomized, and I think this is the biggest in cardiac surgery the last years. And the primary outcome will be a composite postoperative outcome regarding serious adverse events, and the secondary are a lot of other parameters that we are about to study. And as you see here, these are the participating centers. I have highlighted with red the 4 centers that have been so far given interest, and we are recruiting other centers. So to conclude my talk, I think that minimal invasive extracorporeal circulation is associated with improved clinical circulatory support and aortic perfusion, and thus translates into improved outcome, as I have already indicated. But this is not just numbers, it's quality of life that we have proved it's better when you operate on a MIEC system. And of course, it's good for the healthcare system because the cost analysis, at least these 4 countries, showed that there was a beneficial effect towards economics to use of MIEC in cardiac surgery. So the initial schedule I had that MIEC gapped something between all the period between conventional CPB and off-pump. It's not right. This is the evolution of perfusion. So MIEC is the advanced perfusion technique nowadays, and it is the advanced because it's more physiologic perfusion and has to be integrated in the practice guidelines and become the standard practice. Though we should appreciate that this is not a mini system. It's not a simplified system. It's a minimal invasive, so it's more complex and demanding, yet more physiologic. And I will finish with this, answering this question that has been brought up in the literature. 15 years ago, from Jean-Paul Remondy, one of the people that tested this minimal invasive extracorporeal circulation early last decade. So he questioned, is it an evolution or a revolution? And 10 years after, we have all the data to answer this question that minimal invasive extracorporeal circulation is a revolution in perfusion. I want to invite you all, as you've heard from Mark Bennett, to the 3rd MIEC symposium that will be in Bern next June. And also to attend this live webinar from a panel of experts that will be in Thessaloniki this December. Thank you very much.
Thank you, Professor. I think in the interest of time, if it's all right, we carry on with the next talk.